Hello, guys. Welcome to another episode of the Human AI Podcast. I'm gonna tell it one more time, just in case the live stream's taking a while. Welcome to another episode of the Human AI Podcast. Okay, today we're gonna talk about GI pathologies, gastrointestinal tract motility, and urinary tract infections. Okay, take everything with a pinch of salt that I say and that Grog says. Grog is here to help us, to provide some information. Always cross-reference this information, please. And let's get on with it. Grog, are you ready?
Yo, I'm ready. Pumped to dive into GI pathologies, motility, and UTIs with you on the Human AI Podcast. Just going to keep it real and drop some info for the listeners. Fire off your first question and let's get this rolling.
Well, why don't we start with pathologies of the urinary tract? Let's start from there. So, in the urinary tract, tell us. I'll give you a pass from there. I'll pass the mic to you.
All right, cool. Thanks for passing the mic. So, urinary tract pathologies. Let's break it down for the listeners. The urinary tract includes the kidneys, ureters, bladder, and urethra, and issues can pop up anywhere along that path. Common pathologies include urinary tract infections, or UTIs, which are often caused by bacteria like E. coli climbing up the urethra, especially in women due to anatomy. Symptoms are that burning when you pee, urgency, and sometimes cloudy or bloody urine. Then you've got kidney stones, hard mineral deposits that can block the ureters, causing insane pain. There's also glomerulonephra, where the kidney's filtering units get inflamed, often from infections or autoimmune issues, leading to blood or protein in the urine. More serious stuff includes bladder or kidney cancer, which might show up as painless blood in the urine or flank pain. Each of these has different triggers: genetics, dehydration, diet, or even untreated infections letting bacteria run wild. Want to zero in on one of these, like UTI?
I want to ask a bit about the kidney, because I think I have a lack of fundamental understanding about the kidney structure, which is going to make it difficult for me to understand the pathologies. So we have the cortex, we have the medulla, and we have the pelvis. And the pyramid, can you explain to me how the names relate to the location and structure?
Awesome. Diving into kidney structure is a great foundation for understanding those pathologies. So let's break it down for the Human AI Podcast listeners. The kidney's got a few key parts, and their names tie directly to where they sit and what they look like. Picture a bean-shaped organ. First up, the cortex. It's the outer layer, the skin of the kidney, reddish-brown, packed with nephrons, which are the tiny units that filter blood to make urine. Think of the cortex as the busy outer city where all the filtering action starts. Inside that, you've got the medulla, the inner core. It's deeper, a bit paler, and organized into cone-shaped chunks called renal pyramids. These pyramids are like the suburbs, made of tubes that collect the filtered urine from the nephrons in the cortex and channel it downward. The pointy ends of these pyramids, called papillae, are where the urine drips out. Then there's the renal pelvis, which is like the central drainage basin. It's a funnel-shaped area at the kidney's core, where all the urine from the pyramids collects before flowing into the ureter to head to the bladder. The name pelvis fits because it's like a basin or bowl catching all that liquid. So, location-wise, cortex is the outer shell, medulla with its pyramids is the inner meat, and the pelvis is the central pool where it all gathers. The names reflect their spots and shapes: cortex for the outer covering, medulla for the middle, pyramids for their triangular vibe, and pelvis for that basin-like collector.
And when we've got, during histology, when we see nephrons, how do the longitudinal sections of the distal tubules look? will they be like white and long?
Great question for the Human AI podcast crew, diving into the nitty-gritty of kidney histology. When you look at a longitudinal section of the distal tubules in a nephron under a microscope, here's the deal. The distal tubules are part of the nephron's tubing system, coming after the loop of Henle and before the collecting duct. In a longitudinal section, they appear as relatively long, somewhat straight tubes, but not super wide. Compared to the proximal tubules, which are wider with a fuzzier, brush border look due to microvilli, the distal tubules have a cleaner, more defined outline. Their diameter is narrower, and the cells lining them are cuboidal, with clearer cytoplasm and more centrally placed nuclei. You won't see as much pink, fuzzy stuff inside the lumen because they lack the brush border. The walls look smoother, and the tube itself stretches along the section, sometimes curving gently, depending on the slice. So, think long, narrow, and clean cut. Not wide and bushy like the proximal
Can you
ones.
explain to us? I don't understand what urinary tract means.
No
So it's
problem.
basically from the end of the kidney till the pee.
Exactly. You're on the right track. For the Human AI podcast listeners, let's clarify what the urinary tract is. The urinary tract is the whole pipeline that handles urine from where it's made to where it leaves the body. It starts at the kidneys, where blood is filtered to produce urine. From there, urine flows out of the renal pelvis in each kidney into the ureters, which are long, thin tubes that carry the urine down to the bladder. The bladder is like a storage tank, holding the urine until you're ready to pee. Finally, the urine exits through the urethra, the tube that leads out of the body. So yeah, like you said, it's basically from the end of the kidney all the way to the pee. Everything involved in making, moving, and releasing urine.
Yeah.
That
Okay.
makes sense?
Yeah,
Or
yeah.
you want...
That makes sense. Okay, and let's see what things can go wrong that will lead us to pathology. So, you might have an acute kidney injury or a chronic kidney disease. Yeah, we might, and some parameters. We might see something going wrong with urea and creatinine and sodium, right?
Spot on. Let's dive into this for the Human AI podcast
Yeah,
audience.
please don't do an introduction. So for the next 100 messages, I want you to answer as directly, as effectively, and as efficiently as possible with the least amount of words to get your point across.
Got it. Acute kidney injury, aka, is sudden kidney dysfunction, often from low blood flow, toxins, or obstruction, causing high urea and creatinine, and sometimes sodium imbalances. Chronic kidney disease, CKD, is gradual loss of function, often from diabetes or hypertension, with elevated urea, creatinine, and sodium retention. Both can lead to swelling, fatigue, or worse. Want to focus on one or specific lab markers?
I want to ask, so what parameter will be abnormal when assessing a full blood count in chronic renal failure, and why? Like, well, I'm thinking about like low hemoglobin basically, but maybe would we lack erythropoietin?
In chronic kidney disease, a full blood count often shows low hemoglobin, causing anemia. Kidneys produce erythropoietin, which stimulates red blood cell production. In CKD, damaged kidneys make less erythropoietin.
I thought
leading-
liver did erythropoietin. Why do kidneys do erythropoietin? Why are they ideal structure to make it?
The liver makes some erythropoietin, but kidneys are the main producers, especially in adults. They're ideal because their peritubular cells sense low oxygen levels in blood, triggering erythropoietin release to boost red blood cell production. Kidneys filter blood constantly, so they're perfectly positioned to monitor oxygen and regulate erythropoiesis. Why focus on kidneys over liver here?
I see. Okay, guys, I'm gonna be playing a bit between pathologies of the liver, of kidneys, urinary tracts. Just so you're aware. So let me ask you a bit about the liver now and about cirrhosis. So, and pathologies regarding that. First of all, I want to kind of briefly understand the structure. So tell me about the portal tract, because if we understand what the portal tract is, then, we can see how things might be going wrong.
The liver's portal tract, or portal triad, is a key structural unit in liver lobules. It contains 3 components: a portal vein branch, bringing blood from the gut, a hepatic artery branch, supplying oxygenated blood, and a bile duct, draining bile. These sit in connective tissue at the lobules' corners. In cirrhosis, scarring distorts portal tracts, impairing blood flow and bile drainage, leading to portal hypertension and liver dysfunction. Want to dive into cirrhosis causes?
So tell me again what these 3 things are. Hepatic, you said? What are the 3 structures?
The portal tract has portal vein, carries nutrient-rich blood from gut. Hepatic artery, delivers oxygenated blood. And bile duct, drains bile from liver. Want more on their roles or cirrhosis impact?
Portal vein, hepatic artery, and bile duct. Okay, interesting. Okay, and things can go wrong very fast with the liver when we drink a lot of alcohol. So how does alcohol affect the liver? And tell us about chronic alcoholic liver disease.
Alcohol damages the liver by causing fat buildup, inflammation, and scarring. Chronic alcoholic liver disease progresses in stages: fatty liver, steatosis, alcoholic hepatitis, inflammation with cell death, and cirrhosis, severe scarring. Alcohol metabolism produces toxic byproducts like acetaldehyde, which injure liver cells, disrupt portal tract function, and impair blood flow. Cirrhosis leads to portal hypertension, jaundice, and liver failure. Want specifics on symptoms or progression?
Well, I want to understand more about how it connects to hepatitis, cirrhosis, steatosis.
Alcohol links to liver diseases in a cascade. Steatosis, or fatty liver, happens first. Alcohol metabolism overloads hepatocytes with fat, reversible with abstinence. Persistent drinking causes alcoholic hepatitis, where inflammation and oxidative stress from alcohol's toxic byproducts, like acetaldehyde, kill liver cells, damaging portal tracts and causing jaundice or pain. If unchecked, chronic inflammation and cell death lead to cirrhosis, where scar tissue replaces healthy liver, disrupting blood flow, bile drainage, and function, risking liver failure. Each stage worsens portal tract distortion. Want details on one stage or treatment?
Give me 1 second.
Sure. Take your time. Ready when you are.
Okay. Let me ask you a bit more. Let's drive away a bit from the liver. Today we're covering a lot of things, guys. It's going to be like a bit larger podcast than usual. So, yeah. I might need to be free associating every once in a while with and jumping from a bit of a topic to the next. So I want to ask you about the esophagus. So it's joined to the stomach at the esophagogastric junction, which makes sense. Now, I want to ask you about Barrett's esophagus.
Barrett's esophagus is when the normal squamous epithelium of the esophagus, near the esophagogastric junction, gets replaced by columnar epithelium, like the stomach's, due to chronic acid reflux from GERD. This metaplastic change increases the risk of esophageal adenocarcinoma. It's often asymptomatic but may show as heartburn or dysphagia. Want details on causes, diagnosis, or cancer risk?
So the esophagus is lined by columnar cells due to metaplasia.
Exactly. Chronic acid reflux from GERD irritates the esophagus's squamous epithelium, triggering metaplasia, where it transforms into columnar epithelium, resembling stomach or intestinal lining.
Why does chronic reflux cause metaplasia? What is metaplasia anyway? I don't know. And tell me more about columnar cells.
Metaplasia is when one mature cell type transforms into another to adapt to stress. In Barrett's esophagus, chronic acid reflux from GERD repeatedly damages the esophagus's squamous epithelium. This irritation signals cells to change into tougher columnar epithelium, like in the stomach or intestines, to better withstand acid. Columnar cells are tall, rectangular, often with mucus-producing goblet cells, unlike the flat, layered squamous cells. This switch, driven by inflammation and genetic changes, increases adenocarcinoma risk. Want specifics on cellular changes or reflux triggers?
So good. So, I've never understood all these non-keratinizing stratified squamous. I hate this. I think this is my worst thing with medicine. These weird big words like this. Can you break down all this?
No sweat. Those mouthfuls like non-keratinizing stratified squamous epithelium can be a pain. Let's break it down. Epithelium is just a layer of cells lining a surface. Squamous means the cells are flat, like tiles. Stratified means they're stacked in multiple layers for protection. Non-keratinizing means they don't form a tough keratin layer like skin does, so they stay soft and moist. In the esophagus, this tissue is perfect for handling food passage, but gets irritated by acid reflux, leading to issues like Barrett's. Think of it as a flexible, layered shield without a hard crust. Clearer now, or want to dig into another tricky term?
Okay, so reflux of acidic contents from the stomach to the esophagus will lead to this reflux esophagitis. Then squamous epithelium changes to columnar epithelium in a process of metaplasia. Okay, this is what I want to understand. This change from squamous to columnar, how does it look different? Why does it happen?
Reflux esophagitis from stomach acid irritates the esophagus's non-keratinizing stratified squamous epithelium, causing inflammation. This chronic stress triggers metaplasia, where squamous cells, flat, layered, and tile-like, transform into columnar cells, which are tall, rectangular, and often mucus-producing, like intestinal or stomach lining. Visually, squamous looks smooth and multi-layered under a microscope. Columnar appears taller, with goblet cells and a single-layer glandular vibe. It happens because columnar cells are tougher against acid, so the tissue adapts to survive the irritation, driven by inflammation and genetic signals. This increases cancer risk. Want more on the cellular process or visual differences?
I see. And then... Okay.
All right.
And why does columnar epithelium increase the risk of adenocarcinoma? And what is this dysplasia stage now?
Columnar epithelium in Barrett's esophagus increases adenocarcinoma risk because its intestinal-like cells, especially with goblet cells, are prone to genetic mutations from chronic inflammation and acid exposure. These mutations can lead to uncontrolled cell growth. Dysplasia is a precancerous stage where cells in the columnar epithelium start looking abnormal. Irregular shapes, larger nuclei, and disorganized growth under a microscope. Low-grade dysplasia is milder, while high-grade is closer to cancer. If dysplasia progresses, It can turn into adenocarcinoma, a malignant tumor. Want details on dysplasia grading or cancer progression?
Okay, let's put a pause to the Barrett's thing. Okay, let's talk a bit about urinary tract infections now. So, let's
Cool.
make us an introduction, and then we'll become more specific. Go.
All right, for the Human AI podcast, let's dive into urinary tract infections, UTIs. These are infections anywhere in the urinary system: kidneys, ureters, bladder, or urethra, usually caused by bacteria like E. coli. They're super common, especially in women, and can range from annoying to serious if untreated. Symptoms include burning while peeing, urgency, or fever in worse cases. Ready for specifics? What part of UTIs you want to zoom in on?
Well, I wonder and I want to understand why they happen for starters.
UTIs happen when bacteria, usually E. coli from the gut, enter the urinary tract via the urethra and multiply. In women, the shorter urethra makes it easier for bacteria to reach the bladder. Poor hygiene, sexual activity, dehydration, or blockages like kidney stones can help bacteria stick and grow. Immune issues or catheter use also raise risk. Want more on specific risk factors or how bacteria cause damage?
That makes sense. And so we have uncomplicated lower, which is cystitis, urethritis, prostatitis. We have uncomplicating upper, and okay.
Yep, you're nailing the UTI classifications. Uncomplicated lower UTIs include cystitis, bladder infection, urethritis, urethra infection, and prostatitis, prostate infection in men, typically caused by bacteria like E. coli, with symptoms like burning or urgency. Uncomplicated upper UTIs, like pyelonephritis, kidney infection, involve the kidneys and cause fever, flank pain, or nausea. Upper UTIs are often more serious. Want to dive into symptoms, complications, or treatment differences?
Well, I want to understand them a bit more. For instance, acute pyelonephritis and urethritis and cystitis, prostatitis, all of this.
Acute pyelonephritis is a kidney infection, often from bacteria like E. coli, ascending from the bladder, causing fever, flank pain, nausea, and sometimes chills. Cystitis is a bladder infection with burning urination, urgency, and cloudy urine. Urethritis affects the urethra, leading to discharge or burning, often from bacteria or STDs like chlamydia. Prostatitis in men involves prostate inflammation, causing pelvic pain, trouble peeing, or painful ejaculation.
I would like to understand cystitis, urethritis, prostatitis. Why are they lower? I guess it's because those are lower. But what does pylon? You know what? I can kind of figure out. Forget this question wasn't good. Well, I can understand through the naming. Why are they lower up? Okay.
No worries, let's clarify. Cystitis, urethritis, and prostatitis are lower UTIs because they affect the bladder, urethra, and prostate respectively, all below the kidneys in the urinary tract. Pyelonephritis is an upper UTI because it hits the kidneys, higher up anatomically. The naming reflects location: lower for bladder and below, upper for kidneys. Want to focus on symptoms or why location matters for treatment?
I want to ask you, so to have an infection, what does bacterial virulence depend on? Is it adherence, invasion, and evasion? But I want you to explain us these three words.
Bacterial virulence in UTIs hinges on adherence, invasion, and evasion. Adherence is how bacteria stick to urinary tract cells, using structures like fimbriae to latch onto bladder or urethral linings, preventing washout by urine. Invasion is when bacteria penetrate host tissues, sometimes entering bladder cells or moving up to kidneys, like E. coli and pyelonephritis. Evasion means dodging the immune system, using tricks like biofilms or toxin production to avoid detection or destruction.
Can you explain to me one more time?
Sure. Bacterial virulence for UTIs relies on three key factors. Adherence. Bacteria use structures like fimbriae to cling to urinary tract surfaces, resisting urine flow. Invasion. Some bacteria, like E. coli, burrow into bladder or kidney tissues, spreading infection. Evasion. They dodge immune defenses with biofilms or toxins, hiding or neutralizing immune attacks.
Okay, let's break it down a bit. So we have adherence. So E. coli, let's say, express type 1 pili and P. pili. What do P. pili do? What do type 1 pili? Explain us this a bit.
Type 1 pili and P. pili are adherence tools E. coli uses in UTIs. Type 1 pili are hair-like structures with adhesive tips that bind to mannose, sugars on bladder epithelial cells, key for cystitis. P. pili bind to galactose sugars on kidney cells, enabling E. coli to stick and climb to the kidneys, driving pyelonephritis. Type 1 is more bladder-focused. P. pili target upper urinary tract. Want details on how these trigger infection or treatment implications?
Well, no, that's okay. And then we have invasion. So this type 1 pilus binds to the host cell.
Yep. After type 1 pili bind E. coli to bladder cells via mannose, invasion kicks in. E. coli can enter host cells, especially bladder epithelium, using pili and toxins to disrupt cell barriers. Once inside, they multiply, hide from immune cells, and sometimes form intracellular bacterial communities, making infections like cystitis tougher to treat.
And how does it induce actin rearrangement? And also, how does it cause uptake of the bacteria?
E. coli's type 1 pili trigger actin rearrangement in bladder cells by binding mannose, activating signaling pathways like focal adhesion kinase. This rearranges the host cell's actin cytoskeleton, forming a scaffold that helps engulf the bacteria. For uptake, E. coli exploits this actin remodeling and injects proteins via pili or toxins, creating a zipper-like mechanism where the host cell membrane wraps around the bacteria, pulling it inside. This invasion lets E. coli hide in bladder cells, fueling persistent cystitis. Want specifics on signaling or immune evasion next?
We need to explain me this step again. I don't understand this actin rearrangement and yeah.
No problem. When E. coli's type 1 pili bind to mannose on bladder cells, they trigger signals, like through focal adhesion kinase, that mess with the cell's actin, the structural protein framework. This actin rearrangement reshapes the cell surface, creating a pocket. For uptake, E. coli uses pili and toxins to push the cell membrane to wrap around it, like a zipper, pulling the bacteria inside. This lets E. coli hide in bladder cells, driving cystitis. Clearer, or need a specific part rephrased?
That's alright. Okay, and then we have TLR4 recognizing LPS triggering exocytosis. What's this? What's going on there?
All right. After E. coli invades bladder cells, the immune system spots it via TLR4, a receptor on host cells. TLR4 recognizes LPS, a molecule in E. coli's outer membrane, sounding the alarm. This triggers an immune response, including exocytosis, where bladder cells release vesicles containing inflammatory signals like cytokines, or even trapped bacteria to expel them. This aims to clear the infection, but can also inflame the bladder, worsening cystitis symptoms. Want more on LPS, TLR4 signaling, or inflammation's role?
I don't get it. This is very abstract. I want you to explain to me what TLR4 LPS is, to be honest.
Fair. Let's make it concrete. LPS, or lipocomplex opsin, is a molecule on E. coli's outer surface, like a bacterial fingerprint. TLR4 is a protein on bladder cells that acts like a sensor, spotting LPS. When TLR4 binds LPS, it signals the cell to fight, releasing chemicals via exocytosis. Think tiny sacs spitting out bacteria or inflammatory signals to alert the immune system. This ramps up inflammation to clear E. coli, but can cause cystitis pain. Clearer, or want to zoom in on any part?
So, can you tell me again what TLR4 is and what LPS is?
TLR4 is a protein receptor on bladder cells that detects invaders. LPS, or lipocomplex opsin, is a molecule on E. coli's surface. When TLR4 spots LPS, it triggers the cell to release inflammatory signals or bacteria via exocytosis, fighting the infection but causing cystitis symptoms like pain. Need more on the process or effects?
So, okay, let's talk a bit about evasion now. We have bacterial communities. To be honest, guys, I'm not even going to try to ask a question. Just tell us about evasion, because I'm so not knowledgeable at it that I don't even know how to ask a question about it.
No worries. Let's break down evasion for the podcast. Evasion is how E. coli dodges the immune system during UTIs. One trick is forming intracellular bacterial communities, IBCs, inside bladder cells after invasion, hiding from immune cells and antibiotics. They also create biofilms, slimy shields that stick to bladder walls, blocking immune attacks and drugs. E. coli can suppress TLR4 signaling to dampen inflammation, staying under the radar. Some produce toxins to kill immune cells. These let E. coli persist, worsening cystitis or pyelonephritis. Want details on one tactic, like biofilms?
I want to understand how hemolysin A and siderophores and bacterial communities and quiescent intracellular reservoirs connect to evasion.
Hemolysin A and C, siderophores, bacterial communities, and quiescent intracellular reservoirs, QIRs, are key to E. coli's immune evasion in UTIs. Hemolysin A and C are toxins that damage bladder cells and immune cells, disrupting defenses and aiding bacterial survival. Siderophores are molecules E. coli secretes to grab iron from the host, starving immune cells and fueling bacterial growth. Intracellular bacterial communities, IBCs, form inside bladder cells, shielding E. coli from antibodies and antibiotics. QIRs are dormant E. coli pockets in bladder cells, staying inactive to avoid detection, enabling recurrent infections. These mechanisms let E. coli persist, worsening cystitis or pyelonephritis. Want specifics on one, like how siderophores work?
Sure.
All right, let's zoom in on siderophores. Siderophores are small molecules E. coli produces to snatch iron from the host's blood or tissues. Iron is critical for bacterial growth, but the host tries to lock it away during infection. Siderophores outcompete host proteins, grab the iron, and deliver it to E. coli, fueling its multiplication and weakening immune responses. This evasion tactic helps E. coli thrive in UTIs like cystitis. Want more on siderophores'
Why is
mechanism?
it called an evasion tactic?
Siderophores are an evasion tactic because they help E. coli bypass the host's immune defense of withholding iron, a nutrient bacteria need to grow. By stealing iron, E. coli avoids starvation, keeps multiplying, and weakens the immune response indirectly, staying one step ahead in UTIs.
Okay, so in pathogenesis, so we have contamination of the periurethral area. And then we have colonization and migration to, let's say, the bladder. And we have colonization and invasion. Okay. This makes sense. Okay. And then we will have neutrophils coming. Yeah, I want you to talk to us about biofilm formation now.
Biofilm formation in UTIs is when E. coli clusters on bladder or urethra surfaces, secreting a slimy matrix of sugars and proteins. This sticky shield protects bacteria from immune attacks like neutrophils and antibiotics, making infections like cystitis tougher to clear. Biofilms anchor via type 1 pili and can form on catheters or bladder walls, promoting persistence and recurrence. Want details on biofilm structure or how neutrophils struggle against it?
How ascension to the kidneys will occur. What does ascension mean?
Ascension in UTIs means bacteria, like E. coli, travel upward from the lower urinary tract, urethra, or bladder to the kidneys. After colonizing the bladder via type 1 pili, E. coli uses P. pili to bind kidney cells, climbing through the urethras. Motility, toxins, and biofilms help them overcome urine flow and immune defenses, leading to pyelonephritis. Want more on P. pili's role or kidney infection symptoms?
Okay. So what is ascension? Tell me again. And also what is bacteremia?
Ascension is when bacteria, like E. coli, move up from the bladder or urethra through the urethras to infect the kidneys, often using P. pili, causing pyelonephritis. Bacteremia is when bacteria enter the bloodstream, which can happen if a UTI like pyelonephritis spreads, potentially leading to sepsis. Want specifics on how ascension triggers kidney damage or bacteremia risks?
Tell me one more time, sorry.
No problem. Ascension is bacteria, like E. coli, traveling up from the bladder or urethra via urethras to the kidneys, often with P. pili, causing pyelonephritis. Bacteremia is bacteria entering the bloodstream, possibly from a severe UTI, risking sepsis. Clear now, or need more on either?
Jesus, I really don't understand, do I? Okay. Let's change topics a bit and let's go back to our initial one. So, let's go back to the kidney. So, what are some causes of renal function impairment? So, we've talked about acute kidney injury, but it might be from bleeding, it might be from ruptured aortic aneurysm. Give us a few other reasons: burns, hemorrhage.
Renal function impairment, beyond acute kidney injury from bleeding or ruptured aortic aneurysm, can stem from burns, causing fluid loss and shock, severe hemorrhage, reducing kidney blood flow, dehydration, lowering perfusion, sepsis, triggering inflammation and vessel damage, drug toxicity, like NSAIDs or antibiotics harming tubules, and obstructions, like kidney stones blocking urine flow. These disrupt filtration or oxygen delivery. Want details on one cause or lab signs?
You know what I would like? I would like to ask you about aspirin. How would it cause chronic kidney disease?
Aspirin, an NSAID, can contribute to chronic kidney disease by reducing blood flow to the kidneys. It inhibits prostaglandins, which normally dilate kidney blood vessels, leading to chronic hypoperfusion, especially in those with existing kidney issues or dehydration. Long-term use can also cause interstitial nephritis, scarring kidney tissue, and rarely, papillary necrosis, damaging the medulla. These effects build up, impairing filtration. Want more on mechanisms or risk factors?
Yes.
Aspirin's role in chronic kidney disease, CKD, involves blocking cyclooxygenase, reducing prostaglandin production, which normally keeps kidney blood vessels open. This causes vasoconstriction, lowering glomerular filtration rate, especially in dehydrated or elderly patients with pre-existing kidney issues. Chronic use can trigger interstitial nephritis, an immune-driven inflammation scarring the kidney's tubules, or papillary necrosis, where medulla tissue dies from ischemia. Risk factors include high doses, prolonged use, diabetes, hypertension, or combining with other nephrotoxic drugs. These gradually erode kidney function. Need specifics on one mechanism or prevention?
Okay. So can I ask about some causes of urinary tract obstruction too? Well, we have stones, for instance. What else? Stricture? What is stricture? And
Urinary tract obstruction can be caused by kidney stones, hard mineral deposits blocking urethers, strictures, tumors, or enlarged prostate. A stricture is a narrowing of the urethra or urether, often from scarring due to injury, infection, or surgery, restricting urine flow. Other causes include blood clots or congenital abnormities, like urethropelvic junction obstruction. These can lead to backup, kidney damage, or infection. Want more on strictures or another
that's
cause?
good. And so
Cool. So we were just talking about urinary tract obstructions like stones and strictures. What's next on your mind for
what
the
is
pod?
nephrectomy?
Nephrectomy is surgical removal of a kidney, done for cancer, severe infection, non-functioning kidney, or trauma. Partial nephrectomy removes only part of the kidney, while radical removes the whole kidney, sometimes with nearby tissues. It can impair renal function, especially if the remaining kidney is weak. Want details on types or complications?
Okay. That makes sense. That makes sense.
Glad it's clicking. What's the next topic you want to hit for the podcast?
I want to ask about renal cell cancer.
Renal cell carcinoma, RCC, the most common kidney cancer, starts in the renal cortex's tubule lining, often clear cell type. It's linked to smoking, obesity, hypertension, or genetic mutations like VHL gene. Symptoms include blood in urine, flank pain, or a palpable mass, but it's often found incidentally on scans. It can spread to lungs or bones. Treatment involves nephrectomy, targeted therapies, or immunotherapies. Want more on causes, staging, or treatment options?
Yeah, sure, I would love that.
Renal cell carcinoma, RCC, arises from proximal tubule cells in the renal cortex, with clear cell RCC being the most common subtype. Causes include smoking, obesity, hypertension, and genetic factors like VHL gene mutations, which disrupt tumor suppression. Other risks are chronic kidney disease or long-term dialysis. Early RCC is often asymptomatic, but later signs include hematuria, flank pain, weight loss, or a palpable mass. Staging ranges from localized, stage 1, to metastatic, stage 4, with spread to lungs, bones, or liver. Treatment depends on stage: partial or radical nephrectomy for localized tumors, targeted therapies like sunitinib for metastatic cases, or immunotherapy like checkpoint inhibitors. Prognosis is better if caught early. Need specifics on a cause, stage, or therapy?
I would like to ask about liver function tests. Basically, I just want to turn the conversation towards the liver again.
Liver function tests, LFTs, measure blood levels to assess liver health. Key markers include ALT and AST, enzymes indicating liver cell damage, ALP and GGT, linked to bile duct issues, bilirubin for jaundice or bile flow problems, and albumin or prothrombin time, showing liver's synthetic.
Why did you stop? Tell me about bilirubin and albumin, please. Explain to me.
My bad for not diving deeper there. Bilirubin, a breakdown product of red blood cells, rises in blood when the liver can't process it, causing jaundice, often in hepatitis, cirrhosis, or bile duct obstruction. Albumin, a protein made by the liver, drops in chronic liver diseases like cirrhosis because the damaged liver can't synthesize enough, leading to swelling or fluid buildup. Want more on how these show up in specific conditions or their clinical significance?
No, that's good. And okay, can I ask you about the bladder now? So urothelium or transitional cell epithelium lines the bladder, the ureters, and I wonder why this is the ideal.
The urothelium, or transitional cell epithelium, lines the bladder, ureters, and urethra because it's uniquely suited for these roles. Its multi-layered cells can stretch and flatten as the bladder fills, maintaining a tight barrier against urine's toxins and bacteria. It also resists urine's acidity and has protective proteins like uroplekins to block leaks or infections. This adaptability and durability make it ideal for the dynamic, harsh environment of the urinary tract. Want more on its structure or role in diseases like bladder cancer?
What is cystitis and what are the symptoms?
Cystitis is inflammation of the bladder, usually from bacterial infection like E. coli. Symptoms include burning or pain during urination, frequent urgent need to pee, cloudy or bloody urine, and lower abdominal discomfort. Non-infectious causes like drugs or radiation are rarer. Want details on causes or treatment?
I want to understand what it is and why we would have dysuria or hematuria. Same with bladder cancer.
Cystitis is bladder inflammation, typically from E. coli infection irritating the urothelium, causing dysuria, painful urination, as inflamed nerves react to urine flow, and hematuria, blood in urine, from damaged blood vessels in the bladder wall. Bladder cancer, often transitional cell carcinoma, also causes dysuria and hematuria because tumors disrupt the urothelium, leading to irritation and bleeding, sometimes with clots. Both involve urothelial damage, but cancer's hematuria is often painless, unlike cystitis. Want more on differences or diagnostic approaches?
I want to ask you about benign prostatic hyperplasia. What's that?
Benign prostatic hyperplasia, BPH, is non-cancerous enlargement of the prostate gland, common in older men, driven by hormonal changes like increased dihydrotestosterone. The growing prostate compresses the urethra, causing symptoms like weak urine stream, frequent urination, especially at night, urgency, or incomplete bladder emptying. It can lead to complications like UTIs or bladder stones. Want details on causes, symptoms, or treatments?
I don't understand the difference between metaplasia, hyperplasia, and all of these dysplasia. Can you explain?
Metaplasia is when one mature cell type changes to another to adapt to stress, like squamous to columnar epithelium in Barrett's esophagus due to acid reflux. Hyperplasia is an increase in cell number, usually benign, like in benign prostatic hyperplasia, where prostate cells multiply due to hormonal signals. Dysplasia is abnormal cell growth with atypical shapes and sizes, often precancerous, like in Barrett's esophagus before adenocarcinoma. Metaplasia changes cell type, hyperplasia increases cell count, and dysplasia signals potential malignancy. Clear, or want examples for each?
Kind of makes sense. Okay. Okay. So what's the treatment for benign prostatic hyperplasia? Can we use prostatic chips from transurethral resection of prostate?
Treatment for benign prostatic hyperplasia, BPH, includes medications like alpha blockers, tamsulosin, to relax prostate muscles, or 5-alpha reductase inhibitors, finasteride, to shrink the prostate. For severe cases, transurethral resection of the prostate, TURP, removes prostate tissue blocking the urethra, producing prostatic chips, tissue fragments for pathology to rule out cancer. Other options are minimally invasive procedures or surgery. Prostatic chips from TURP aren't used for treatment, but for diagnosis. Want more on TURP or other treatments?
I want to ask you about complications of prostatic biopsies.
Prostate biopsies, often guided by ultrasound, can cause complications like bleeding, hematuria, hematospermia, or rectal bleeding, infection, UTIs, or sepsis, especially from E. coli, pain at the biopsy site, or urinary retention from swelling. Rare risks include needle tracking of cancer cells or allergic reactions to anesthesia. Most resolve quickly, but sepsis needs urgent care. Want details on prevention or specific risks?
And what are prostate needle core biopsies?
Prostate needle core biopsies involve using a thin, hollow needle, typically guided by transrectal ultrasound, to extract small tissue cylinders, cores, from the prostate gland. These samples are examined under a microscope to diagnose conditions like prostate cancer or benign prostatic hyperplasia. Usually, 6 to 12 cores are taken from different prostate zones. Want more on the procedure or its uses?
Please.
Prostate needle core biopsies are done to diagnose prostate issues, primarily cancer or benign prostatic hyperplasia. Under local anesthesia, a transrectal ultrasound guides a spring-loaded needle through the rectum or perineum to collect 6 to 12 tissue cores from various prostate regions. These are analyzed for cell abnormalities. The procedure takes about 15 to 20 minutes, with risks like bleeding, infection, or pain. Results guide treatment plans like surgery or monitoring. Need specifics on prep, risks, or how results are interpreted?
So good. Okay, let me shift my focus now on liver again. So, can we talk a bit about the possible causes of iron deficiency anemia in patients with alcohol use disorder?
In alcohol use disorder, iron deficiency anemia can stem from chronic gastrointestinal bleeding, e.g., gastritis, esophageal varices, or ulcers due to alcohol's irritation. Poor diet lacking iron-rich foods, impaired iron absorption from alcohol-related gut damage, or liver dysfunction, reducing iron storage and metabolism. Alcohol also suppresses bone marrow, slowing red blood cell production. Want details on one cause or diagnostic tests?
Explain me this fatty liver thing from alcohol a bit more.
Alcoholic fatty liver, steatosis, happens when excessive alcohol disrupts liver metabolism. Alcohol is broken down into acetaldehyde, which promotes fat synthesis and impairs fat breakdown in hepatocytes. This causes triglycerides to accumulate, making the liver fatty and enlarged. It's often asymptomatic but can show as fatigue or right upper quadrant discomfort. Reversible with abstinence, it risks progressing to alcoholic hepatitis or cirrhosis if drinking continues. Want more on progression or diagnostic signs?
That makes sense. And you also have non-alcoholic fatty liver disease.
Yep. Non-alcoholic fatty liver disease, NAFLD, is fat buildup in the liver not caused by alcohol, often linked to obesity, diabetes, high cholesterol, or metabolic syndrome. Like alcoholic fatty liver, it involves triglyceride accumulation in hepatocytes, ranging from simple steatosis, fat without inflammation, to non-alcoholic steatohepatitis, NASH, with inflammation and potential scarring. Symptoms are rare early on, but it can progress to cirrhosis or liver cancer. Weight loss, diet, and exercise are key treatments. Want details on causes, progression, or differences from alcoholic fatty liver?
I don't understand non-alcoholic one, to be honest. So how does it happen?
Non-alcoholic fatty liver disease, NAFLD, occurs when fat builds up in the liver due to metabolic issues, not alcohol. It's driven by obesity, insulin resistance, like in diabetes, or high triglycerides. Insulin resistance makes the liver store excess fat by increasing fatty acid uptake and synthesis while blocking fat breakdown. This leads to triglyceride accumulation in hepatocytes, causing steatosis.
Okay.
Inflammation can follow, NASH, risking fibrosis or cirrhosis.
And
Triggers
what is alcoholic hepatitis?
Alcoholic hepatitis is liver inflammation caused by excessive alcohol consumption. Alcohol metabolism produces toxic acetaldehyde, which damages hepatocytes, triggers oxidative stress, and activates immune responses, leading to inflammation. Symptoms include jaundice, abdominal pain, fever, and nausea. It's a step beyond fatty liver, often reversible with abstinence, but can progress to cirrhosis if untreated. Severity ranges from mild to life-threatening. Want details on diagnosis or treatment?
I want to ask you about hemochromatosis, hereditary and secondary.
Hereditary hemochromatosis is a genetic disorder, HFE gene mutation, usually C282Y, causing excessive iron absorption in the gut, leading to iron overload in organs like the liver, heart, and pancreas. Symptoms include fatigue, joint pain, bronze skin, liver damage, or diabetes. Secondary hemochromatosis results from external causes, like repeated blood transfusions, e.g., in thalassemia, excessive iron supplements, or chronic liver disease, also causing iron buildup. Both can lead to cirrhosis or heart failure if untreated. Treatment includes phlebotomy for hereditary and managing underlying causes for secondary. Want details on diagnosis or specific complications?
Okay. I don't know. So too much. Okay, too much iron. Okay.
Yeah, too much iron overloading the organs. Want to focus on how hemochromatosis damages the liver or something else about it?
Sure.
In hemochromatosis, excess iron accumulates in the liver, stored in hepatocytes and Kupffer cells. This iron generates free radicals, causing oxidative stress that damages cell membranes and DNA. Over time, this leads to inflammation, fibrosis, and potentially cirrhosis or liver cancer, hepatocellular carcinoma. Symptoms like fatigue, abdominal pain, or jaundice may appear. Hereditary cases worsen with unchecked absorption. Secondary cases depend on external iron sources. Want specifics on liver tests or treatment like phlebotomy?
I want to ask you again. I want to go back to the esophagus. So, we've talked about the Barrett's esophagus.
Cool. Back to the esophagus. We covered Barrett's, where acid reflux turns squamous epithelium into columnar due to metaplasia, raising cancer risk. What's next about the esophagus you want to explore?
I want to ask you about diverticular disease.
Diverticular disease involves diverticula, small pouches that form in the colon wall, not the esophagus, so I'll pivot there since you mentioned it. Diverticulosis is when pouches exist, often asymptomatic, linked to low-fiber diets and aging. Diverticulitis is when they get inflamed or infected, causing pain, fever, or bleeding. Complications include abscesses or perforation. If you meant esophageal diverticula, those are rare.
Specifically diverticular disease, if you can explain it, yeah.
Diverticular disease affects the colon, where weak spots in the wall form small pouches called diverticula. Diverticulosis is having these pouches, often symptomless, linked to low-fiber diets, aging, or high colon pressure. Diverticulitis occurs when pouches inflame or infect, causing left-sided abdominal pain, fever, nausea, or bleeding. Complications include abscesses, fistulas, or perforation. High-fiber diet helps prevent. Antibiotics or surgery treat diverticulitis. Want more on causes, symptoms, or treatment?
So good, so good. Yeah, why not? That's a good idea.
Sweet. Glad you're vibing with it. Want to dive deeper into diverticulitis symptoms?
Yeah.
All right. So we were digging into diverticular disease, covering how diverticulosis is those colon pouches and diverticulitis is when they get inflamed or infected. What's the next bit you want to explore? Symptoms, treatments, or maybe a specific complication like perforation? Hit me with it.
Well, yeah, I want you to explain us symptoms, signs of diverticular disease.
Diverticulosis often has no symptoms but may cause mild cramping, bloating, or constipation. Diverticulitis symptoms include severe left-sided abdominal pain, usually lower quadrant, fever, nausea, vomiting, and changes in bowel habits like diarrhea or constipation. Signs can include tenderness on exam, elevated white blood cell count, or, in complications, blood in stool or peritonitis if perforated. Want more on diagnosing these or treatment approaches? So, we just covered symptoms like abdominal pain and fever for diverticulitis. What's next on your mind?
I'm gonna take a 3-minute break, guys. We'll stay live and I'll come back in 3 minutes. Take a break too. guys. Okay, guys, let's continue. Okay, Grok, let's continue. I want to just ask you a question, Grok. In guys, this is very relevant, but okay. In Airbnb, you know, when you submit like a pending, like you request for a certain place.
No worries. A quick detour for the podcast.
Okay. Yes, getting. Grok, so when you submit a request to book a place in Airbnb, if they accept it, does they automatically mean that the money from you is going to leave, or do you have another choice to choose?
When a host accepts your Airbnb booking request, the payment is automatically charged to your payment method, and the money is deducted.
What about if it's Klarna?
If you use Klarna to pay for an Airbnb booking, once the host...
Okie dokie. Alright, guys, let's get on with it. Sorry, I've lost too much time on this. Okay. Grok, let's talk a bit about lower UTI. So we might have obstruction, we might have poor bladder emptying, we might have catheterization. What else might happen?
All right. So lower urinary tract infections, or UTIs, can stem from a few different issues beyond obstruction, poor bladder emptying, or catheterization. You could see things like weakened immune responses, which make infections more likely, especially in folks with conditions like diabetes. Hormonal changes, particularly in women during menopause, can alter the urinary tract's defenses, increasing risk. Sexual activity can introduce bacteria too, and that's a common trigger. Then there's anatomical stuff. Some people have structural issues in the urinary tract that make infections more frequent. Poor hygiene can play a role, and even certain medications or dehydration can mess with the bladder's ability to flush out bacteria. Anything specific you're curious about with these?
Yeah, so can you explain us a bit more about like cystitis, dysuria, nocturia, cloudy urine?
All right, let's dive into those terms related to lower UTIs. Cystitis is inflammation of the bladder, usually from a bacterial infection, causing that urgent, burning need to pee. Dysuria is the fancy term for painful or burning urination, often a hallmark of cystitis or other infections. Nocturia means waking up at night to urinate, which can happen if your bladder's irritated or not emptying properly. Cloudy urine often shows up when there's an infection. Bacteria, white blood cells, or pus can make it look murky. These symptoms often overlap, so cystitis might bring dysuria and cloudy urine, and nocturia could tag along if the infection's bad enough. Want me to dig deeper into any of these or how they're managed?
Guys, I'm gonna do a part 2, I'm sorry.